Cystic fibrosis is a monogenic autosomal recessive disease in which the gene encoding the cystic fibrosis transmembrane regulator, CFTR protein, is mutated. Over 1,950 mutations have been identified that affect the structure and function of CFTR protein, in which patients manifest multi-system symptoms in the body. These manifest in the liver, gastrointestinal tract, lungs, pancreas, and the reproductive system. Clinical diagnosis relies on an elevated sweat chloride level, with normal levels being 20 millimolar per litre. 1 in 2,500 Australians are born with cystic fibrosis. Our friend Kate must follow a regimented treatment plan to preserve her quality of life. She is highly dependent on her nebulizer to deliver medications including bronchodilators and mucolytics to relieve her persistent cough. Kate also relies on a range of daily oral medications to maintain digestive function and prevent respiratory infection. Normal functioning of the CFTR regulates chloride and water through the membrane, effectively clearing mucus buildup. Mutations in this system obstruct these ion channels and congest in the mucus-secreting organs. Kate has the most common mutation, delta F508. This is a class 2 mutation whereby misfolding of the CFTR protein prevents itself from being transported to the cell membrane. Our treatment will use the CRISPR-Cas13 system to provide specific and efficient knockdown of RNA. The PSP-Cas13b protein will be used compared to other Cas13 orthologs to increase the efficiency of the RNA editing. This system will contain single guide RNA as a template for the mutant mRNA. Additionally, RNA coding for the correct CFTR protein will be delivered with the CRISPR-Cas13b. We will use non-viral nanoparticles to deliver the gene editing system. The nanoparticles will be made from polypeptide-based zwitterionic aminolipids, ZALs, containing a sulfobutane head group, an amine-rich linker region, and hydrophobic tails. These will protect from nuclear degradation and reduce immune attacks. These will also have cell-penetrating peptides and a dissociable mucus insert coating to overcome the mucus barrier. The nanoparticles will be synthesized into an oral drug which will be delivered in a once-daily dosage in the morning. The drug's cellular uptake occurs via pH-sensitive endocytosis, where the neutrality of ZALs allows for endosomal escape and entry into the nucleus for RNA correcting, eventually allowing the creation of a fully functioning CFTR protein, which will leave the Golgi and proceed to the cell membrane. Our drug therapy benefits many CF patients as it targets RNA instead of DNA, avoiding mutational side effects. It uses nanoparticles, which have better biodegradability, biocompatibility, and non-toxicity. Furthermore, the non-invasive co-delivery system of mRNA and Cas13 guarantees delivery to the same individual cells and better editing by increasing molecular interactions within the nanoparticle. This method can also be adapted to any of the 6 classes of CFTR mutation. There are, however, some limitations to this therapy. This strategy has not yet been tested on humans. Designing a nanoparticle platform with higher mucus penetration may improve transfection rate and efficiency of Cas machinery, and drug pharmacokinetics and pharmacodynamics need to be balanced for fewer side effects and better targeting. Thank you for listening. We hope you will seriously consider our proposal.